Great. Well, I think we'll go ahead and get started. It's just past the top of the hour. So welcome to our Bright Spots webinar, Leveraging the Power of Storytelling to Increase Vaccine Demand. Before we get started, I just have some logistics to get out of the way. So if you wouldn't mind going to the next slide, thank you. Just a reminder that we are using a Zoom meeting format today, so that we ask that you please mute yourself when not speaking to limit any background noise and feedback. You can use the reactions button at the bottom of your screen to raise your hand during the session if you'd like to speak. And then, of course, you can always engage in dialogue with your peers and workshop facilitators through the chat button at the bottom of your screen. Next slide. I just want to welcome everyone who might be joining that is not familiar with the Boost community. We are a global community of immunization professionals. We have about 3,000 members in our community. And we often come together through our online platform, boostcommunity.org, to connect and also engage in various trainings and events like the one today. Next slide. And then for those who are new to the Bright Spots series, so Bright Spots shine a light on a work that is happening on the ground, and they seek to inspire immunization professionals everywhere to learn, adapt, and take action in their own communities. So we've now shared out 3 rounds of Bright Spots, and in this most recent round of stories, we have 6 stories from 5 countries, including China, Nigeria, Zambia, India, and Bangladesh. Again, these are innovations occurring at the regional, district, or facility level. So we do encourage you to visit our website, brightspots.boostcommunity.org, to read a little bit more about some of the other stories that I mentioned today. Next slide. So with that, I'd like to actually introduce our esteemed speakers for today. So we have Dr. Nene Awarabi, who's a medical doctor with over 8 years of experience in the public health space. Her interests are in occupational health, epidemiology, disease control, and immunization. She's worked in these fields in different capacities, and presently she works as the Director of Disease Control and Immunization, where she heads the EPI team. We're also joined by Ms. Ghania Ishiani, who's a management consultant with over 5 years of experience in reproductive, maternal, newborn, child, and adolescent health, including nutrition interventions. She currently works with the Corona Management Systems, and she's committed to strengthening health systems at the subnational level. And finally, we're joined by Mr. Adam Don. Mr. Don has over 10 years of experience in deploying ICT solutions in health. He currently works with the Corona Management Systems as an innovation specialist, providing leadership on data and technology-driven innovations in the improvement of reproductive, maternal, newborn, and child health outcomes, and for the containment of COVID-19. So I want to welcome all of our speakers today, and I'm going to hand it over to them to take it away with their presentation. Next slide. And if you're speaking, we cannot hear your audio, so just remember to unmute.
Okay. Good afternoon, everybody. Thank you for introducing me, Liz. I'm Dr. Nene Awarabi Oki. I'm the Director of Disease Control and Immunization at the Bayelsa State Primary Healthcare Board. So our duty is to ensure that every eligible child is immunized in the state. However, sustaining and improving immunization coverage has been an issue in the state, which is located in the Niger Delta region. This is because of many challenges that we have had. We have with our terrain, we have far-to-reach communities. We have communities that you have to go on boats to get there. You can spend over 4 to 6 hours just to get there to administer immunization services. Then there are also communities that are hard to reach, communities that you are not able to reach because, well, their terrain is very, very difficult. Then we have the problem of mixed tenantry farmers, they are fishermen, and they have this migratory lifestyle so that should have gotten immunized. Then another problem we have, another challenge we have with immunization coverage is the problem of zero-dose children. This is as a result of different factors, ranging from hesitancy, ranging from pure refusal for parents to get their children vaccinated, and also from inability of health workers getting to those places. So you have children that have never received a dose of a vaccine, which we measure with Penta 1 coverage. So what we need to improve our coverage are interventions that are comfortable, acceptable by the people, that are friendly with the communities, where the communities can make those suggestions with you. So I'll hand over to Ganiyat, who will tell us what the community team ensure that immunization coverage improves in the Niger Delta region. Thank you.
Thank you very much, Dr. Nenny. So our solution all started on a rainy day a few years ago when we met Mama Coco. Mama Coco is a 36-year-old rural fisherwoman who lives in the heart of the Niger Delta region in Nigeria, who has just lost her 3-week-old baby. She spent some of her time talking to my team and I at a local health center where she shared her pain and her regret. And this conversation was such that she walked us through watching her baby suffer convulsions and spasms and eventually died from tetanus, a disease that we know that vaccination could have prevented. She told us about how she was really excited about the birth of the baby, being the only female among her 7 children, and how she had planned to support the child, knowing that she didn't get a chance because she married early, so she jumped out of school to get married. The conversation had us really angry and upset. One more child lost to the cracks in our vaccination system. Mama Coco's greatest regret was not knowing about tetanus or the vaccination that could have prevented it. At the time we started work on this project with the data available to us in 2019, we had around 1 million of such children that died from vaccine-prevented diseases, with the majority of these children residing in the northern part of Nigeria and the difficult terrain in the Niger Delta region. Around 2 out of every 5 givers that were surveyed in a 2016 national survey indicated a lack of awareness as a key reason for not being immunized. And for us, this was really a future that was not guaranteed. At that time, a fundamental question we therefore needed to answer was, how can we empower these caregivers and activate communities to seek and fully utilize available immunization services? Our intervention was spawned by a need to empower caregivers like Mama Coco to tell their own stories, educating and amplifying the positive and real stories that can create demand for vaccination, using them as both actors and champions that can cause that change in their own local communities. After all, there is no one better suited to tell this story than these women who have experienced some of these issues or have had life experiences working and knowing how it can get with immunization. So this is us tapping into what 200 plus years of our African folklore storytelling, where you see elders telling tales by moonlight to kids and teens to inculcate values and morals. Specifically in health, storytelling and community theater has worked in the HIV program. It has helped in the conversation around gender-based violence and particularly driving the restoration post-violence in Rwanda. Prioritizing the zero-dose strategy of improving coverage and equity by fully vaccinating children in rural, marginalized and mixed communities, we were able to identify and clearly map out communities ranging from rural to urban and hard to reach, and even mixed communities, clearly describing what the gaps were. We had to listen to the communities to really understand what the key contributors of the issues were, being health system or community issues. Of course, we also be able to extrapolate that against the enabler. So simply put, what we wanted to do was, how does demand look like, and what does supply look like, and how can we get them to meet? We tailored the strategies to suit individual communities, knowing that every community is unique and every community is different. And we wanted to cause a linkage towards integrating the health services. We used the human-centered design. We had extensive user research to understand our primary user and what it means to be them in their everyday lives, what their drivers of demand were. We co-created and prototyped with the users, learning critical lessons about what their cultures were and what their behavior. Our solution really was flexible, that we were able to collect feedback and continue to iterate to make the theater performances better. So we would use local languages to make the theater performances come alive and it's easy to resonate with the caregivers, songs and dance routines in addition to the drama pieces to tell these stories. Costumes, of course, props make the experiences very relatable and enjoyable. A key part of the community theater intervention is to apply creative stories and anecdotes that really harnesses the powerful role that emotion play in driving decision making. And in this case, it's demand for vaccination services towards a sustained, long-lasting, positive behavior change. The theater performances targeted community dialogue meetings, women meetings, women gatherings, marketplaces, as well as religious gatherings as a part of a design strategy to ensure that the performances fit into the established routines of the users. So imagine after I had this job in the farm, or selling at the market, or at the river fishing, you're able to join other women at the town hall or the night market. Watch yourself create theater pieces that we all will enjoy. And while we're learning about vaccines and vaccine preventable diseases, and there is an added advantage of getting your kids vaccinated. We've put a matchup for you to see some of the moments we had working with the communities and how it all went. I'll be back.
There's a cry from a young boy in a city running wild. There's a cry from a mother who just lost another child. There's a cry from a people who have nothing more to lose. Everything that they live for has been wasted and abused. There's a cry from a river. That only heaven knows. Where did they go wrong? How can we go on? Only hope remains the answer. There's a man on a mission.
If I carry Justin to go health center and then give her vaccine, the kind of stuff not going to catch on the day. Yellow you miss yourself.
He has gone for the people, and a promise yet to come. So they kill one another for a hope that never comes. There's a cry from a river that has nowhere to flow. And the pride of the river was lost so long ago. And I cry for a reason that only heaven knows. Where did they go wrong? How can they go on? Only hope remains the answer.
So what do you think? Fun, right? It was really beautiful working in this community, I must tell you. So we went through a number of processes and had some assumptions as to how we did this. The community theater was built to test certain hypotheses that caregivers would demand for immunization services as a right if they're engaged through a human-centered design of trust building and education and reconnection to the health system. So upon commencement of the project, we had several opportunities to design with the relevant government stakeholders, starting with the mid-level managers and the immunization team, and then to the leadership of the health system at the subnational level. Firstly, to secure buy-in, and then we went on to co-create and prototype with them. So we used administrative data that was available at state to select the district with large numbers of zero-dose children, prioritizing urban and rural LGAs or districts. So after that, we had more deliberate designing opportunities with the districts, immunization teams. And again, we wanted to secure their buy-in. We went on to get their program reports with them, then selected the mixed communities and communities where they had high numbers of zero-dose children. We identified the communities and the health facilities that were serving these communities that we needed to do this. Then we went on to the community health workers to secure their buy-in because they are the heart of the implementation and they were in charge of everything. We did assessments with them to understand the facility relationship with their community and what the determinants of demand was as it related to immunization and also integration with other primary healthcare services. It was really important to secure the buy-in and the collaboration of the health system as this was supply. And of course, you know, when you create demand and there's no supply, it becomes problematic. Then we went on to engage the community leaders. The leadership of the community included the community head, the woman leader, the WDC, World Development Committee leader, the youth leader, religious leaders, and other opinion and group leaders in the community. And we also secured their buy-in. I must tell you, the people were really welcoming and they offer us gifts like drinks to show appreciation and collaboration. Communities provided counterpart contributions by providing community assets to support the implementation like town halls, churches, market squares, and even town announcers that will go around to make announcements about the performances. And sometimes light refreshments were also done. We particularly saw buy-in in some communities more than others. And I must commend the communities that had really active women leaders. They would convene the women without hassle and even responsibility for next steps. With the help of the women leader and the community health worker in the community, we recruited women for our focus group discussion, selecting women of childbearing age, having children under 5, and ultimately picking women, picking users and non-users of the health facility just to get a good representation of the caregivers in the community. We proceeded to having themes along the drivers of demand, talking about awareness, acceptance, intention to seek care and action, and documenting the stories with them. Went on to we then went on to developing storyboards. So the storyboards were developed using what we map as the hero's journey. We had two distinct hero's journey, the health worker and the caregiver. So depending on whose story we're telling, we'll be able to identify which one we wanted to use. We had a handful of caregivers coming for rehearsals, or should I call it audition? I call it that because that is what we saw from the co-creating process with the women. They became their own directors, and judging from how this person did a better job, or this person would be better for this role, we would have simulations to judge who was better, and they decided by themselves. So our work was really easy. We had women that, as part of the co-creation, they said, oh no, let's change this line, let's put it like this, let's speak this part, there's this line in our local dialect and in our own, the way we spoke, and this will be better. So they actually wanted the plays to come alive and what it means for them to really execute these roles. Before rehearsals proper, we had opportunity to train them about vaccines and vaccine preventable diseases, because we knew we needed to equip them with the right message for both the plays, and of course they are not champions and they could go to spread the word. We understood that these caregivers were not professional actors. It is one thing to be able to tell your story, and another thing to be able to participate in your story or in a real story. So like I mentioned, we had an assumption about this, and we had amazing discoveries about this assumption, with the caregivers coming out with their own costumes and props, and also for them to direct the scenes, deciding on the dance routines and songs that would particularly resonate with the story we're trying to tell. And even a community did something very unique. So the cast and the health worker in a particular community believed that the community would not understand if we used, if we called the vaccine preventable diseases in the names in English. So they were able to give us majority of the vaccine preventable diseases in their local language, and they used that for the play. And you can really see that it really resonated, and people really understood more about what you were trying to say. We then we started prototyping and testing with the cast, where they were their own directors and their own audience. So it's a whole spectrum of dance, song, drama. Yeah, trust me, I can give you some dance lessons now. So if you want, just contact me. The timing, the date, the venue for the performances were selected with the community and the health worker as aligned with their real micro plans. As part of the co-creation process, the caregivers will volunteer their own costumes to make the theater pieces better. Now, action. Let me tell you about the first performance we had. So we've had many and several town announcements days prior to the performance and even up to the day of the performance. And when time came, everything was ready. The stage, the sound, the cast, everything was ready. Well, we found only a few people coming out for the performance. I particularly said, the show must go on. Let's go ahead and work with the ones we had. The women refused. They couldn't go through all of this process, and a few people would see. They said they wanted to share their learnings and their acting skills, especially with the costumes they had on. So most people needed to see that. So they picked up their drums and other musical sets and did a community work, singing and telling everybody to come out. And in no time, we had people. That is how we have continued to use this community work to help and complement the town announcement. The plays typically will last for 45 minutes, and as a part of our feedback, we collect at the end of the performances, we saw that 70% of the audience responded that the duration was adequate. Also, we also wanted vaccines to be available at the place, and this would involve us doing a lot of planning with the health worker and sometimes with the district coaching officer to ensure that is done. So we were able to administer vaccines to eligible pregnant women and under 2 children. Some caregivers with eligible children will vaccinate, and we also made conscious effort to support the health worker and other children that got 0 dose at those places, using their phone numbers to follow up. So we'll do telephone reminders and reporter tracking. And some that particularly missed communities that were flood prone. So it's seasonal. So at some part of the year when we have this heavy downpour, you see everybody leave the community. So we needed to do an extra one, either the health worker would go to those IDP camps to vaccinate, or if they're not there, they'll have to link them up to the nearest health facility to continue their sessions. So like I mentioned, we have a feedback tool to document the experience and how the theater made them feel. And we'll be able to use this feedback to iterate, and that is how it goes back as we continue to work with the stakeholders of the health system and the community. Ultimately, we saw around 4% of the number of under-immunized and 0 those children within the community. So we did baseline surveys. So baseline surveys form part of our information gathering in the inspiration phase of our human-centered design. We collected data relating to the immunization status of children in the community and documenting some of their reasons for not being appropriately vaccinated, categorizing them into issues around information, motivation, and trust. So we wanted to monitor the progress as related to their behaviors and the trend of the change. So we did midline and endline as a result. The intervention reached 18 of these missed communities in 3 districts, and we vaccinated around 400%, of which 23% of them were 0 dose children. Results from the intervention clearly demonstrate an increase in knowledge of over 200 activated community champions, which are the caregivers who act in the play, as they were trained and equipped to support their communities to seek immunization services. We also saw a reported increased acceptance of vaccinations by the audience, and significant declines in proportion of the caregivers that were in the intervention communities who report either a lack of information, lack of trust, or lack of motivation as a reason of the 1,000 complete vaccination from the surveys we had. So the results demonstrate an important experiential pattern in deploying theater through human-centered design, with reported satisfaction by the attendees, within a positive net promoter score and utilization of the available vaccination services that were provided in the theater performances. Okay, so we all know how the world stood still with the emergence of COVID-19 and how it affected the general global health and even economies. And one of the big issues for us, community theater, was how do we rise to the challenge of the global pandemic that was in front of us? We implemented performances taking into consideration the public health and social measures, also considering the more pressing need of building vaccine confidence in such a critical time. So we tried to ensure the use of face masks as much as possible. We provided hand washing stations, sanitizers to enforce IPC, and we pivoted some of our performances to speak to the concerns around COVID-19 vaccine and also build that general vaccine confidence. So ultimately, this project has shown that leveraging on the power of storytelling for demand for vaccination has the potential for being a game changer in increasing demand for any health service. There's no ownership without participation. Designing with the communities ensured that we listened to them and responded in a way that addresses their most important challenge in demanding and utilizing vaccination services. And also designing and collaborating with the mid-level managers, both at sub-national and district levels, the community health workers, the community leaders, the community members, and even partners having gain. And this was the crux of why community theater really succeeded, because it had everybody that needed to collaborate. They were really on the table.
So the community theater for immunization is a very special intervention to us. This is because we saw results from this intervention, and we're able to pick out the critical success factors that ensure that this intervention brought out the required results. We saw the use of design thinking, where the problems of the people were put in the center, and the thinking was done by them, through them, and the performances and the interventions was all human-centered, where the community members, the middle actors, the frontline workers, and then those at the state level, the major decision makers took part in it. We also saw the use of storytelling, which is an age-long tradition of people in the Niger Delta. This attracted them, this brought their interest in the intervention, and it sustained it over a period of time where it was being used. Then the critical players, all the partners involved, WHO, UNICEF, the state, everybody was carried along, and so the intervention was a success. We were able to reach 0 children, we were able to reach missed communities. So this intervention is something that we think has a future in the Niger Delta. So I'll hand over to Dawn to tell us what we think about the future of community theater for immunization.
And I think you might be on mute, so just a reminder, unmute, please.
Right, so sorry about that. Yeah, so my colleagues and I we've walked you through the implementation context within which we found ourselves. We've talked about how we applied design thinking and leverage the power of storytelling to increase the demand for vaccines. We've talked about the impact we succeeded in having and the critical success factors we had. At this point, I think we are much like on an inflection point, and we'd like to take a peek into the future and see what does the future look like for community theater for immunization. Yeah, so the WHO and the stakeholders within the global routine immunization strategies and practices has recognized community involvement as one of the 9 transformational investments to achieving better immunization outcomes. And as we've seen Gani explain over the past few minutes, community involvement was actually at the heart of community theater. So our use of design thinking within community theater, it allowed us to apply a human-centered design in trying to solve what is indeed an age-old question in the global health problems. Now, the successful application ultimately holds endless potential for us, and it really gets us excited about the possibility of using design thinking in a community involvement project. And what is even more exciting was that we were able to pull this off smack in the middle of a pandemic. I mean, a pandemic where we all saw a lot of decreasing vaccine confidence. But then again, our excitement is really much of the questions that this successful implementation bubbles up. It's more of the questions that this successful implementation poses to us. And honestly, although we have more unanswered questions, we still remain very much optimistic about the future. Now, within our project, we did succeed in identifying missed communities and communities with large number of zero-dose children. Although we lean very heavily on administrative data and program data, thankfully we worked very closely with the states, so we were able to get this data. We also know that there are wonderful and innovative interventions like the use of GIS in microplanning, which we've seen that has helped us hotspot missed communities. I mean, it's been part of the polio program over the years. So the question is now is that how can we apply community theater through program reports and admin data that these interventions has provided us? How can we apply that and basically latch on to this kind of GIS interventions such that in a country or a locale where these missed communities has been identified, we can basically sweep in, intervene there using all the pluses that we've just listened to over the past few minutes of community theater, and basically intervene there and get results. I mean, what potential does this have for us? How remarkable do we see this? And in terms of the work that community theater has done in being able to reduce the number of zero-dose children in intervention communities. So we ask ourselves, how do we incorporate an intervention of this nature that drives community involvement using a human-centered design, and then leveraging the power of emotions, the power of storytelling? So how do we integrate this kind of intervention within zero-dose operational planning in countries, especially looking at Gavi high-impact countries where there's a strong commitment to eliminating these zero-dose cases? Now, implementing community theater for immunization, it showed us that educating and entertaining caregivers, triggering and appealing to emotions, raising immunization champions in these communities, all in the process of empowering these caregivers, we saw that it led to sustained service utilization. So how then can we leverage this community theater even better to reach caregivers of under-immunized or zero-dose children? These are indeed some of the questions that keep us awake at night after our successful implementation. And yet again, we have to think about a totally different context. So community theater was implemented as a face-to-face intervention, but we are looking at the possibility of using digital media. So how can we leverage technology to disseminate local theater performances? I mean, these performances that tap into people's cultural heritage without losing the personal and cultural touch. How would you feel, or how will millions of people all over the world feel watching a YouTube or a social media video on performances that are steeped in their own culture? How do we tell the stories that people can relate to? How can we amplify the reach of this unique vaccine messaging? How can we build this trust building process that we've seen work for us in community theater? And how can we integrate technology to trigger these emotions? I mean, over the past over the past few years, we've seen that technology has played a great role in almost every facet of our lives. So we know technology has a role to play here, but we have to be a bit coy about it, because we don't want to lose this human-centered approach. We don't want to use the specificity that we've seen with the community theater. So we ask ourselves, where does digital media fit in? How can we create contents for different cultures and settings and disseminate them using social media, which will be as part of the broader strategy to build vaccine confidence? There are indeed endless possibilities to which we can amplify this successful approach. One success we had in Bayelsa State, that is our intervening state, we were able to add community theater into their work plan So in Bayelsa State now, community theater is part of their work plan. So we are sure that community theater will go on, and it's sort of a means of sustainability where the state has taken this over. But we want to think about scale. How can we get to new heights? How can we meet new partners, new conversations, new engagements? So I think particularly we've looked at, for instance, UNICEF, who are drivers of innovation, who are very big on the human-centered design. We'll be looking at Gavi, who care about eliminating zero dose cases and whose investments and interventions are in this direction. The future indeed holds endless, and I'm almost sounding like a broken record, but we are very much excited about this. And ultimately for us, we choose to remain very much excited, and we are going ahead on this journey. And we would like to invite you to come along with us on this journey over the next 3 years as we look to increase coverage and improve equity across countries, all in our bid to ensure child survival and to ensure a guaranteed future. Thank you very, very, very much for this opportunity to share our story with you. So at this point, I think we are happy to hear your thoughts, your questions, and let's see how we can take the conversation from there. Thank you very much.
Wonderful. Well, thank you so much for that fascinating presentation and such a great intervention, and the thoughtful process that you put in place, and the feedback loop just involving the community as well has been fantastic. We've gotten a few questions and comments in the chat so far. I think a couple have been answered, but I'm not sure if you want to maybe elaborate a little bit more. There was a question around if the community still organizes community theater activities, is the intervention still ongoing? So kind of beyond maybe the implementation period. And I know that I think there was an answer to that, but I'm not sure if you wanted to elaborate on that a little bit more. And if not, there's another question that we have coming from Zachariah. So have you evaluated the sustainability, the cost benefits of the intervention? And I'm not sure if yeah, looks like there might be some answers there. I'm not sure if anyone is able to voice over the answer as well from the Corona side. No. Great, and feel free to continue asking your questions in the chat as well. I guess I have a question from my side. I'm wondering if you can share some of the effective strategies that you use to encourage government buy-in for the intervention.
Maybe I'll just go right in. I was just trying to sort out network. Okay, so for us, at the very beginning, we understood how it was important to co-create with government, and of course, there were other interventions that partners were also doing, and how we can all come together to be able to work together and reach the same outcomes, or that was the objective is the same, to reduce those children and reduce these communities. So for us, it was really important to get that government buy-in and for us to work together in making it work, knowing this was a small, should I say, a small pilot. So of course, before you can say, okay, this works, and you'll be able to expand and go to other places, you needed it to also be aligned with what government was doing and how it fits into other priorities that partners were also working in, looking at the different partners that were working in Niger Delta on immunization. So for us, it was just really important to dovetail this into what government was doing, but knowing using the government workers as well. So it's just aligning it into what the government was doing, aligning into what the drive was for immunization. And I would say it was easy after that, after we got the buy-in of government.
Great, thank you so much for that. And I realized, I think that we might have accidentally had someone on mute. So wanted to just go back to the cost benefit question.
Yeah. So yes, we've been able to do a cost benefit for this. And like we mentioned before, some of these communities were willing to give out some of the things that would have been of cost, and they gave it for free, like talking about their assets, the town halls or the marketplaces. Ordinarily, if you're going to be paying for halls, of course, we know that will always increase the cost of the performance as it is. Sometimes we get support looking at refreshment for the community, looking at costumes and town announcements. You know, in some communities, you would need to go around to you pay the person that will go around, or even to fuel the community generator that would do the announcement. But in some of those communities, we got them for free as part of their own contribution, and it wasn't, you know, posed or imposed on them. It was more of what they could have done, and it was easy to get back. And so we'll be able to do this. So we have them, you can just, you know, use them, and it was really easy to being able to remove some of those costs that would have made it really expensive. So currently, what we would usually say are costs are really not so much per se. It's more like we were there to give that to guide the women in how to tell the story, not to back the stage, just normal theater pieces and technical guidance on immunization messages. But the rest was them. So, and that's why it was really important to align with them, to understand what timing works with them, knowing that you're not adapting them. They can't leave their normal daily lives, come and just set up pieces. So they had to go to work, as an example, they had to go for their normal days, go to the market or go to fish. So it was really aligned. So we've done the cost, but trust me, everything being equal is not anything you would worry about, knowing that it was aligned to what the government was doing, and also what the users were onto the users' own lives, as it were.
Great, thanks so much for elaborating on that. I also wanted to ask a question, and this was kind of alluded to at the very end around the future and potentially recording performances, putting them online through social media. I'm wondering if you've already tried to do that and kind of what results you've had so far. And I'd also be interested in learning kind of, you know, how do you then measure that engagement? It's obviously a different reaction than applause, you know, from those in-person performances. But I guess, what are you looking for in terms of that online engagement with the material that you're putting out there?
Hi, Coco, you want to take that?
Sure. Right. So yeah, as I mentioned, we do have a lot of unanswered questions. So we know there's a possibility, there's an opportunity here, but our major thing is that we don't want to lose that the human-centered design approach, which we mentioned. So somebody listening in a far away country, we want to be able to align the story sort of to something that they can relate to it. So honestly, the measurement we have now will be a little bit average measurement, because I mean the stories might not relate to you. So these are what we think we need to explore deeper, and we're looking on how we can either do specific stories to specific regions, or again, we don't have the answers yet, but I mean these are one of the questions that keep us up awake at night, and we're sure that we will explore this and see how we can share these stories to people all around the world to relate to stories that are steeped within their own cultures. And it's definitely going to be interesting, but maybe we don't have answers on that yet, but we'll definitely research that further.
That sounds great. It sounds like there's a lot to learn, and I'm sure having material in different languages and yeah, further contextualizing it would just make the stories more impactful. So we're getting another question as well. So kind of following along the lines of the technology to expand the reach of some of these stories. Could you share maybe how to do that in especially resource constrained settings? And if there's any insights, I guess, and I know that you're also in the preliminary stages of doing this, but some things that you're thinking through perhaps as well.
Okay, I thought Coco was going to jump on this.
Sorry, Gani, I totally missed the question.
Okay, so they're asking us on how we want to use technology to expand the reach for the performances and what we're thinking around, such constraint settings and what we can typically do.
So right, so I think it boils back to almost the same answer we gave. So we've seen how I don't know. There's a lot of, if anybody's on social media, there's a lot of short stories, short scripts, short plays that happens now. But with community theater, we did not use professional actors. We use these actual mama cocos that experience these interventions, but their story is unique to themselves. So we're trying to find out a way to, like as you just mentioned, different languages, different cultures, different environment. We want to be able to pattern these to specific people. Again, we don't have all the answers yet, but we know that we definitely have to leverage technology to disseminate this to meet people all over the world. So if you're somewhere abroad and you listen to a play in your language or in that you can totally relate to, that will appeal much more to your emotions. And we've seen that community theater appealing to emotions gives us the success we are looking for.
Great, thank you so much for that. I think we've answered all of the questions that are in the chat box so far, but definitely encourage you to continue to ask your questions there, or afterwards, you can always continue the conversation on the Boost community platform, and we can share them with our presenters from today's session. So with that, I might ask that if you could just click to the next slide. I'll just go through a few next steps. Just a reminder, I know that we've gotten some questions around if the slides and the recording will be shared afterwards, and the answer is yes. So we'll be emailing all of those resources to you if you register for the webinar, which obviously you have because you're in the session. And then we'll also be posting those resources on, again, the Boost community platform, which is boostcommunity.org. You can sign up for a free member account in order to access that platform. We also have a Telegram channel that we've set up just to send out reminders of all of our live sessions and announcements that are going out. So I encourage you to join that channel. And I believe all these links should be shared in the chat box. We also have a Bright Spots learning group on the Boost community platform, which is featured here. And again, this showcases all of the stories that we have. We invite our storytellers to actually come share their stories in live engagements like the one today. So we have several of those other stories recorded as well, and would welcome you to access those resources. And then last but not least, we're going to share a link to a survey just to evaluate today's session so we can get feedback and continue to improve our live engagements moving forward. And then on the next slide, I just wanted to bring your attention to a couple events that are coming up in the Boost community. So next Monday, we're going to be having a session in partnership with I8 2030. So that's the Immunization Agenda 2030. They are launching a scorecard and they're looking for feedback from our community. So that should be a really interactive session. We'll be doing breakout rooms to get your feedback, so encourage you to attend. We also have another event coming up on the 14th of June, which is part of our Behavioral Science and Immunization Network. Again, some more details are being shared in the chat box, so encourage you to check that out. And then last but not least, just the other day, we launched a call for applications for a new course that we're hosting in partnership with the JSI's MRight program on gender and immunization. And the deadline to apply for that course is June 15th. It's a 4-part course. It's going to be very exciting. Again, I know gender has been kind of a hot topic in the last year or so. So we're looking on, strategies to actually integrate gender into some of the immunization strategies that you're currently working on. I think with that, that's all I had from my side. I want to thank all of our presenters again for just an excellent presentation. I want to thank all of our attendees for participating and asking those questions. And again, hope to see you on the Boost Community platform and at future live engagements. Thanks everyone. Enjoy the rest of your Friday and have a great weekend.